Thank you, Dr. Amalia Cochran, for talking to us about burn care and some of the changes over the past 10, 20 years. Could you please give the audience a little bit of biographic data? What is your specialty, and whatever you'd like to say about your background?
Absolutely. So I am a burn and critical care surgeon at the University of Utah in Salt Lake City. I'm one of 3 burn surgeons in our unit. We have a huge geographic catchment area. It's about 1/11 of the land mass of North America, so we get burns from basically all over the Intermountain West. I have been here on faculty for almost 9 years now. I did my general surgery training here in Utah as well, and I did my burns and critical care fellowship at Shriners in Galveston.
Okay, great. And I did my burn rotation, not rotation. I did my burn training in Detroit in about the late '90s, and it seemed like there were several things in flux at the time. And I'm curious what has come out of that. And so I'd like to touch on a couple things, starting with resuscitation. At the time, it was there was a mathematical equation that said, give them 198 cc's of lactated ringers per hour. I'm curious over time what has come out about resuscitation and the importance of the formulas versus managing by urine output.
Absolutely. We still do tend to use the traditional formulas, either the Parkland formula or the consensus formula, as a starting point for resuscitation from burn shock. But we've really started to emphasize a lot more that it is strictly that, a starting point. Because what we have found over the years is that you don't just have complications from under resuscitation, which is what we used to do before we understood that people needed resuscitation from their burn shock, but there are also complications associated with over resuscitation.
Okay. Mm-hmm. And do you therefore start with one of the formulas and then go by urine output or other clinical measures? How else do you look at volume with ultrasound, or how do you assess volume after initial resuscitation?
So urine output is still the gold standard, so to speak. And excuse me, cat tail wandering across.
That's great.
She is not helping. And so urine output is still what we start with. Mm-hmm. But we don't hesitate to use other measures. There have been some publications that have shown that using lactate, just to sort of give you some idea where you are in terms of if it's correcting or not, can be helpful. If a patient's got a really elevated hematocrit that's not coming back down, they're probably intravascularly hemoconcentrated. In our unit here, we actually did do an experiment for a while with doing kind of quick and dirty transthoracic echocardiography just at the bedside. And I did actually find that it was helpful. We were doing it on about an every 6-hour basis. And what I was finding was that it was starting to show me hints that someone was getting a little behind on their resuscitation before their urine output even was showing me that.
Oh, is that right?
Yeah.
Okay. And in terms of the fluid that you typically use, are you starting with lactated ringers?
Everyone still seems to start with lactated ringers. Crystalloid with the addition of colloid has been a subject of big controversy. There was a Cochrane review that came out for all critical care patients that basically said colloid is bad and burns. A lot of us in the burn world have fought that really hard because the trials that were included in it, none of us felt like were methodologically terribly rigorous, and so we felt like that was sort of a spurious finding. In our center and in some other centers, we've actually been able to demonstrate that albumin rescue for a patient who's falling off the curve, if you're having to go up and up on their colloid or their crystalloid and they're not responding to that in terms of urine output, we here add in a 1/3, 5% albumin, 2/3 crystalloid mixture, and we have actually found that that's very successful at sort of retrieving people back. It's not 100%. We still have patients we just can't resuscitate, but we've found it to be really beneficial.
Okay. And that was interesting to hear that you followed lactates as well. I don't recall that. Is the elevation in lactate felt to be due to global hypoperfusion, or is that from tissue tissue damage?
It's absolutely due to the global hypoperfusion. It's an indicator of anaerobic metabolism.
Okay. And how about grafting? Has anything changed much in grafting in the past 10, 20 years?
You know, grafting is one of those areas where we've been slow to make any big changes. And I sort of tease our residents all the time that what you see us doing now isn't tremendously different from what we were doing a number of years ago. One of the things that really remains one of the challenges in burns is coverage. Best coverage is still with people's own skin. We don't have a great cultured allograft source at this point.
Oh boy, there were lots of promises, it seemed, when I was going through that rotation.
Yeah, there's been a lot of, this is going to be our savior for these big burns, and it'll give us a great option to having to take and retake donor sites. A couple years ago, everyone got super excited about the skin gun, and it kind of keeps resurfacing every once in a while. It's promising technology, but the way that I describe it when families or when one of my staff come across it and ask me about it is I say, it's just not quite ready for prime time yet.
Yeah, okay. And how about timing of grafting?
Timing of grafting, everyone's pretty much buying into the paradigm of early excision and grafting. The big question there becomes, what do you mean by early? Because there's been a lot of variation with that. I did my fellowship in Galveston with Herndon, and he wanted all eschar off of everybody within 36 hours of them getting to the burn center there. Mm-hmm. I'm not quite that aggressive in my practice, but I do push pretty hard to get eschar off, and I think you find for most of us that we're using kind of 5 to 7 days for complete excision as our threshold.
Okay. And the attempt to get all the eschar off, is that because of infection risk or bad humors circulating related to the eschar?
All of the above. Certainly the infection risk, because having that dead tissue sitting around, it's just the bacteria look at that and they think, wow, this is a great snack. I'm going to go get some of that. And then it really does drive the inflammatory process. One of the key issues that we've wrestled with for a long time and that we still wrestle with major burn injury is the hypermetabolism that's the response to the injury. And one of the things that has been very clearly demonstrated in the metabolism research has been the fact that just getting eschar off of the patient brings those metabolic demands back down by about 50% from where they get elevated to. It still doesn't bring them back down to normal, but it gets them headed the right direction very quickly.
Okay. And touching on infection again, what about prophylactic antibiotics for infection and about culturing to find infection before treating infections?
We are big believers in culturing. Prophylactic antibiotics we have moved further and further away from. As part of sort of good stewardship practices and antimicrobial care. And also because what we do tend to find in our patients with bigger burns and longer stays is that with more antibiotic exposure, they develop more resistant bacteria when they do get infections. And so we try to be really meticulous about making sure that someone needs that antibiotic before we start them on it.
Okay. And what are the trends in terms of what people are infecting their burns with?
It's really center variable. Almost all burn centers are going to tell you about some fantastic Pseudomonas they have, because Pseudomonas is a bacteria that loves burn wounds. They're warm, they're damp, they're dark. They're a great place if you're a Pseudomonas. But then different centers will have very different patterns in terms of what their key local bug is. For us, besides our Pseudomonas that we tend to grow, it tends to be MRSA, which I'll take and run with because it tends to be less virulent than some of the Acinetobacters or Enterobacters that other centers will get.
Okay. Well, it's kind of a scary thought, though, that the microflora or the infections that people are getting are very center specific, because that sort of suggests that it's the centers giving the infections are being passed from patient to patient.
Potentially, it also probably has to do with endemic bacteria in certain areas. But if you look nationally, not just in burn ICUs, but in any ICU, there are definitely different both microbial patterns as well as patterns of antimicrobial resistance amongst those bacteria. Okay. And it has to do with selection pressures and a lot of other things too.
And if those bacteria are endemic to a center, is it the people probably become colonized at the center? It's not like a regional thing where people in Salt Lake City are colonized with a certain staff, right?
Generally speaking, that's true. And we certainly, we have a lot of infection control measures in place in our unit. Our hand washing numbers are great amongst both our physicians and our nursing staff, as well as our support staff, and we're really proud of that. And that's sort of step one. And then one of the other measures that we instituted probably 15, 18 years ago is that for our burns who are over 20% of their total body surface area, while they have that amount of burn wound open, everyone who goes in the room has to gown and glove in addition to doing their hand hygiene. And that has seemed to cut down on intra-unit transmission of bacteria.
Nice. Okay. So what other big topics am I missing, or what else has happened in the last 20 years, or in the literature, or in clinical trends?
Right. I think that there are some really exciting studies on the horizon that have been accumulating data that are completing enrollment right now, and some are in the midst of enrollment. One of the trials has been, for those who are familiar with the TRIC trial, the Transfusions in Critical Care trial, which came out a number of years ago now. Burn patients were excluded from the TRIC trial, and a lot of us did change our practices to use TRIC as what we did in our burn units, but we don't know that it actually applies to our patients. So there's been a prospective multi-center, basically analogous to the TRIC trial, going on just for burns who are over 20% total body surface area. I think enrollment is anticipated to be concluded later this summer. And so that's sort of one of those coming soon to a meeting near you. Should be some exciting results from that. Another multi-center trial that recently concluded, and some of the findings from it are going to be presented at this year's ABA, had to do with the role of physical therapy, because that was something you alluded to with me earlier, was, when you're traveling in your other places, the real importance of therapy for our burn patients. And what we were able to show, which didn't surprise any of us, which was burn therapy is helpful in our patients, that it's beneficial for them. But the thing that was important about it was that it was able to show that it requires more than just 1 or 2 visits. And that's important data for us to be able to show insurers, because a lot of insurers limit how much physical therapy their covered lives can have. And so if we're able to demonstrate that for burns, 3 outpatient physical therapy visits is wholly inadequate, then hopefully that is a service to our patients in terms of insurers being more generous with their benefits.
So it showed, what were the outcomes in it? I'm curious, was it lack of limb function from?
Yeah, they did a lot of really specific micro-level management. It was primarily a burn therapy study, and so our therapists were who ran it. But they did measurements of function of hands, wrists, elbows, knees, ankles, toes, all of those sorts of things. It was the data that they had to collect for it was sort of unbelievable, but it was a great project to undertake, because we've got data from a lot of different centers put in there, so different ways of managing therapy. But at the end of it, we were able to show therapy matters, and it matters a lot.
Good. Well, thanks so much. Anything else off the top of your head you'd like the world to know?
No. I mean, I think that we continue to have some exciting advances. There's a lot of nutrition and metabolism research. We're still trying to figure inhalation injury out because we don't have that nailed down either. But there's a lot of growth. There's a lot of good clinical research and translational research going on in burns. So I consider it a really exciting time to be a burn surgeon.
Great. Well, those actually sound like another set of topics we can spin off for another day.
Absolutely.
Really appreciate your input. Good talking to you.
Thanks, Chris. Good to see you as well.
Bye. Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.